Risk assessment presentation by Anay Barriga. Patient demographics. Patient is 21 years old, male, Hispanic, and is a full-time student online. He is single and he loves cats. His medical history assessment, his vitals were all within normal limit. He does not have any allergies, does not take any current medication, and he is ASA1. His BMI is 38.5, which lands him on the obesity based on his height, 5.5 feet, weight, 230 pounds. He does have family history on both sides. On his paternal side, he has thyroid cancer due to smoking, and then on maternal side, there's colon cancer. One of the periodontal assessments on the extraoral findings, there was a bilateral skin on posterior side of the ear with some slight edema. And the oral habit, he is a grinder, does not use a night guard, and he does chew on his sweater string, which is something that I did notice during all his appointments. His periodontal assessment on the interoral, we have bilateral on the molar arch relationship. He is a class 3, and bilateral on his right and left cusp, he's a class 1. Overjet is 1 millimeter. Overbite, there's an average of 0 to 1 millimeter. He does have bilateral crossbite and mesonactive profile. He does have open bite between teeth 6, 7, 9, 10, and 11, and edge to edge on tooth number 8. There are some mandibular anterior teeth showing signs of attrition. These are on teeth number 26, 25, 24, and 23. His gingival description for the maxillary, his free gingiva is pink and firm. However, he does have some row bulbous on the facials and edematous on linguals. On the right side, I have a picture here on the linguals where you can see the signs of edematous. Also, row bulbous on the facial of number 15. His attached gingiva is pink and stipple. For his mandibular free gingiva, he mainly had row bulbous on facials, and I did see that they were on the back molars and premolars. Also some edematous on the linguals. The interdental papilla was full and inflamed on teeth number 19, 18, 31, and 30 on the mesial and distal surfaces. The mandibular attached gingiva is pink and stipple. This is his periodontal sharding, where he shows a generalized periodontal probings of 2 to 3 millimeters. He does have some localized periodontal pockets of 4 millimeters. And as you can see, we can see those on the number 2, number 3, 13, 14, 18, 19, 30, and 31. For his PI and MBI, he has a plaque index of 59% and 9.8 on the MBI. His radiographic, he is missing all 4 wisdom teeth, not due to periodontal disease, no orthodontic treatment, no recessions, no mobility. His DMTF is 14. Patient has 0 teeth with decay and 4 teeth missing not due to decay and has 10 existing fillings. He does have a combination of amalgam and composite fillings. As you can see, I have stated here the GV Blacks classification. Overall, radiographic bone loss is no measurable bone loss. Lamina dura appears healthy. Alveolar crest also healthy. No bone loss or defect, no periodontal ligament space, no possible caries lesion. Condition of his dental restoration based on his initial intake appointment in July 30, 2024. The dentist was not concerned about any restorations intact, well, no faulty restorations. No periapical areas of pathology noted. Periodontal classification, he has gingivitis, West LA code line 2, mainly supragingival calculus and subgingival calculus up to 25% of the interproximal surfaces. Dental hygiene treatment versus the actual treatment outcome. So this was his actual starting point, which he said too light. And we were anticipating to be about 5 appointments. The actual treatment that we did per appointment starting September 3rd, 2024. So after we did assessment photos on the first 2 appointments, on 3rd appointment, we did mandibular quadrant scale lower right and lower left, followed by a following appointment to scale the upper right and upper left. And then we reevaluated 4 to 6 weeks, which we fine scale unresolved areas, supragingival and subgingival calculus in the mouth. There was new recurrent lower anterior lingual supragingival calculus. And we also did a full mouth polish and apply 5% fluoride varnish. Recommended next method 3-month recall due to his high plaque index. So oral hygiene instructions given to the patient was vascular sulcular method, which angle at 45-degree placed on the sulcus. I did have the patient show me on a mirror, so tau show do, to do short horizontal strokes on sulcus after a few short vibrations, the brush bristles, and reposition to the next 2 to 3 teeth. Brush 2 times a day, recommended once in the morning and once before bedtime for 2 minutes. So I recommended that 2 minutes. He doesn't need to time it, but he could do the happy birthday song in his head. And the rationale is to remove plaque at the gingival margin and directly below. So when I'm showing patient and he showed me in the mirror, I did do some corrections, but eventually he got it right before he left the appointment. Also recommended a needle bristle toothbrush and to replace 2 to 3 months. Let the toothbrush dry before using it or have a second one handy. Replace toothbrush after contagious illness. Tongue scraper. So I had him extend tongue out, place the tongue scraper on the dorsum of the tongue, clean forward using light pressure, repeat until coating free. The benefit was to eliminate bad odor, reducing bacteria and oral cleanness. Patient does not floss prior to coming to see me. So I wanted to give him something that probably was going to be more easier for him, which is a floss pick. So I had him zigzag motion on his teeth, go up and down against the tooth, just like the C-spoon method. We are recommending antibacterial toothpaste, active ingredient staining fluoride, and the purpose is anti-cavity, anti-gingivitis, and toothpaste, as well as AC mouth rinse. The active ingredient also has sodium fluoride and purpose is anti-cavity. So nutritional assessments and recommendation based on his weight and age, he is recommended to eat 2,400 calories a day. However, his current intake, he eats 2 meals a day, high calorie, all carogenic food, average of 48 ounces of water, mainly sugary drinks, 2 to 3 snacks a day, no physical activities, does less than 30 minutes a day. So some of the recommendations, I did not want to overwhelm him. So I asked who does the food at home. He says mom, but he does not like to eat healthy. I asked if he would try to eat one food at home and then maybe he could eat one fast food a day instead of two. Also adding a banana or apple a day, which will take care of his fruit department, and maybe trying raw carrots as his vegetables, to try to intake at least 1 glass of water every 2 hours if possible, and do a minimum of 30-minute walk a day, and that will help him feel motivated. So some of the articles that I chose was one, Caries Management by Riggs. So mainly Canberra is very important. So this article states that 71% of restorations already done will eventually become secondary restorations. And as you can see, patient already has primary restorations. However, due to his high carcinogenic food, he is highly on the high Canberra risk. And also this is due to not finding the actual risk factor and remaining unsolved. So caries prevention can be successful by altering the complex dental biofilm, changing oral factors to favor health. Therefore, using caries management by risk assessment Canberra, which is an evidence-based approach to determine the factors of dental caries. The second article that I chose was dentifrices with calcium sodium phosphorylase. So this is a study basically stating if dentifrice is beneficial if it's added to if fluoride is added. And the conclusion was if the added ingredient does penetrate and remelains the deeper parts of the ICLs better than the standard fluoridated dentifrices with no such added active ingredients. So yes, fluoride dentifrices do help with deeper incipient caries. That's why we recommended one that has fluoride. And home oral care. So the ADA has gathered information on the importance of home oral care. So it's very important to discuss with your patient 3 things: general recommendations, personal recommendations, and lifestyle recommendations. Every patient will have a customized home oral care based on their needs. This will also reduce disease risk and help educate a treatment plan. Over-the-counter products can also reduce the risk of gingivitis. For example, toothpaste containing triclosan or stannous fluoride, as well as mouth rinses that contain fixed combination of 4 essential oils. Home oral healthcare is very important that we do take the time to explain to our patient and customize it based on their needs. Also, using Canberra is going to help us get them where they need to be. And these are my references.